Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Vive Healthcare.
This program is presented by Medscape Education Global.
Hello and welcome to this program titled Undercover Partners, HIV, Immune Activation and Inflammation. My name's Graham Moyle. I'm a consultant HIV physician at the Chelsea and Westminster Hospital in London in the UK. It's my great pleasure to be joined today by Santiago Moreno of the Department of Infectious Diseases at University Hospital Ramón y Cajal in Madrid. Welcome, Santi.
Hi, Graham. Thank you very much.
So we're going to talk about immune activation. And of course, immune activation is part of the appropriate immune response to invading pathogens, including viral infections. But in the setting of HIV, we get a more dysfunctional chronic inflammatory state with pro-inflammatory mediators, tumor necrosis factor alpha, interferon alpha, various interleukins such as IL-2, IL-8, dysfunctional T regulatory cells, which establish a chronic inflammatory state. And the problem with that is that it creates an inflammatory environment which results in premature aging of the immune system, something that has been called inflammaging, and contributes to an accentuation of comorbidities in people with HIV. When we look at soluble markers of immune activation in people with HIV, they go up after acquisition of HIV, but even the introduction of suppressive antiretroviral treatment doesn't eliminate the persistence of elevated inflammatory markers. So we also can see that a proportion of individuals who experience full suppression after initiating antiretroviral therapy, including prompt initiation of antiretroviral therapy, still maintain persistence of immune dysregulation, activated CD4 cells, activated CD8 cells, elevated T regulatory cells that may result in incomplete immune recovery despite the presence of complete viral suppression. So there are a number of potential drivers of chronic inflammation in the setting of viral suppression of HIV, and I'm going to hand things over to Santi to discuss some of those and how they may contribute to inflammatory states. Before I do that, I just wanted to mention that there may be also sex differences in chronic inflammation, and we've also seen some data around the way women may have different levels of immune activation than men, and how this may contribute to different presentation of comorbidities related to inflammation in women versus men. So still an evolving story. So Santi, let's focus on the drivers of immune dysregulation in people living with HIV. What can you tell us about how they lead to immune activation and suppression of or dysfunction of the immune system?
Well, Graham, this is an important question because, as you said before, this is multifactorial, and even in patients treated for HIV, there are a number of factors that can impact on inflammation. The most important possibly is the replication of HIV, although this is especially important in untreated patients. But as we can see later, this is also important even in patients with successful antiretroviral therapy. Then we have the toxicity of antiretroviral drugs, maybe now less important since we have less toxic drugs. We have also an important factor is the co-infections by other pathogens like CMV, but also hepatitis C virus, hepatitis B virus, HPV, and others. And then the disbalance in the T cell subsets, mainly with the loss of regulatory T cells. And finally, the well-known microbial translocations. All these factors and others may lead to inflammation that at the end underlie the development of comorbidities, the so-called non-AIDS events, which are the clinical problem that we face. I would like to go a little more in depth for two of these factors. The first is microbial translocation. I want to emphasize the fact and the evidence that we have that even in treated patients, this is still an important factor leading to inflammation. You remember well that when HIV infects and soon after the acute infection, the epithelial barrier of the gut is disrupted by HIV, and also there is a loss of the mucosal immunity. All these allowed the gut microbes and the microbial antigens to go into the blood and then activate the immune system and cause inflammation. I like this slide because it shows the infiltration of the gut mucosa by neutrophils, so reflecting inflammation in patients with HIV, even if they are successfully treated. You can see that at your left, we have the gut mucosa in HIV negative individuals, and this is the normal aspect. And then in those treated for HIV, you see the brown spots, which are the neutrophils that are infiltrating the mucosa. And if you compare the two images, this is greater in those with a low CD4 count, but still present in patients with a good immune reconstitution. And the second factor that I wanted to comment on is the persistent viral replication. And I'm showing here a slide of a lymphoid tissue biopsy in patients treated very, very early in the course of HIV infection. In fact, these were patients in the 5-1 stage. You can see in these biopsies, these pink spots, which are the viral RNA, meaning that this patient early treated successfully with antiretroviral drug, still there is viral replication. And why that? Because antiretroviral drugs, most antiretroviral drugs don't attain good exposures in the lymphoid tissues. And you can see in this slide that those green spots, which are the viral RNA, are distributed in the lymphoid tissues where there are less red spots, which are the drug concentration, meaning the virus replicate there when there is less drug, and the poor diffusion, the poor concentration of antiretroviral drugs is also shown in this study, in which you see that in the lymph node, the tissue plasma ratio of the drug is very, very low. And at the right part of the slide, you see that in the lymph node, both the concentration of raltegravir and darunavir are very low, below the therapeutic levels. And one point more to emphasize is that even if we do not have viral replication, we still may detect some P24 RNA and proteins in lymphoid tissue. And this is shown by these green spots in different biopsies. And the fact is that this RNA and protein are also inflammatory. In this study showed that one of these particles, the GP120, can be detected consistently in patients despite viral control. And you see in these three shadowed graphs that even in patients with undetectable viral load, we have significant amount of GP120. And the important finding is that GP120 is also pro-inflammatory and it leads to a cytokine burst in human monocytes, as shown in the graph. And my last point of this part is this one, which I feel is a very interesting study. They showed how important is HIV replication in particles in the development of inflammation and the consequence, which is fibrosis. You have here the picture, the photographs of 4 patients, lymphoid tissue in 4 patients. The Berlin patient that you remember is the patient that was cured of HIV infection with undetectable provider DNA in any tissue, so the virus was eradicated, and then 3 HIV-infected patients, an untreated virectomy patient, and a lead controller, and a patient on ART, and with a good CD4 count. The finding was that in the 3 HIV-infected patients, you could see this blue part of the photograph, which is the fibrosis. And you see that this is especially important in the untreated viremic patient, but it was also detected in the lead controller, those with a natural control of HIV replication, and in those patients treated for HIV and with a good immune reconstitution, where you still see much of the cirrhosis. The important finding is that in the Berlin patients with HIV eradicated, this was reversed. In this biopsy, we couldn't find any fibrosis. So meaning that the patient was not only cured, but also free of the long-term consequences of the infection.
Thank you, Santi. So we're obviously not going to be accessing lymph nodes or rectal biopsy tissues or gastrointestinal lymphoid tissue in clinical practice. What might we use in clinical trials, or when we're reading papers about inflammation? What are the biomarkers we're going to hear about? And what might we consider measuring in clinical practice that may be useful in saying, identifying the people with the most inflammatory change and who we might consider as the potential targets for intervention around inflammation?
Fantastic, Graham. And that's because there is confusion on this point, because I would like to state a few points. First, the different biomarkers that we can use either in clinical trials and less frequently in clinic, they are biomarkers of involved in different pathways of inflammation. There are some biomarkers that reflect the systemic inflammation, others that are related to adaptive immunity, others involved in the activation of monocytes and macrophages, and some that reflect the mucosal integrity. This is a first point. The second one is, since they are associated to different pathways, we have not to expect that they will always go in the same direction and that they will be affected by the same interventions. I mean, we can do something that increases or decreases IL-6, reflecting how systemic inflammation is, but have no impact, on the intestinal fatty acid binding protein, the IFABP, reflecting the mucosal integrity. So I'm saying that because in many clinical trials, they measure different biomarkers of inflammation, and people, feel that they are not translating anything special because one goes up, the other goes down. This is just reflects the fact that they are associated to different pathways. If you want to have a summary of this, these are the most important inflammation we are using, and they are using in clinical trials at this time. ILC and high sensitivity CRP, which are associated with the systemic inflammation, then soluble CD14 and soluble CD163, which are related to monocyte and macrophages activation, IFABP, showing the mucosal integrity, the D-dimer related to coagulation, and the CD4-CD8 ratio that is the only one at this time we can use routinely in clinical practice.
Thank you, Santi. So I'm going to talk a little bit about what the consequences of chronic immune dysfunction are and that the presence of inflammation. We know in other chronic inflammatory diseases, whether it's inflammatory arthritis or chronic inflammatory bowel disease, that there are consequences to inflammation. And we see those things in the setting of HIV as well. And these are accentuations of what we would often think of as chronic diseases of aging. So that would be accentuation of cardiovascular disease, an increased risk of some malignancies, an increased risk of metabolic disorders, including diabetes and insulin resistance, the loss of bone density and bone structural integrity, the development of neurocognitive disorders. And of course, putting all of those additional comorbidities together, we finish up with individuals experiencing sarcopenia and the development of frailty syndromes in the setting of HIV. And there's a wealth of evidence that supports the idea that all of these things are more common in age and sex-matched individuals with HIV infection relative to their friends and colleagues in the general population. When we look at studies such as SMART, which was a study that looked at continuous viral suppression versus treatment interruption and targeting of CD4 numbers, we found that a number of key inflammatory markers were markers of cardiovascular disease. For example, the highest quartile of IL-6 was associated with the largest risk of cardiovascular events. The highest quartile of HSCRP, which we know can also be used in the general population as a marker of cardiovascular risk and can be subject of an intervention. Also, the highest quartile associated with more cardiovascular events, and also D-dimer, the highest quartile of that at entry into the SMART trial was also associated with that. Sandy, what about CD4-CD8 ratio? You mentioned this as perhaps the one we can access most readily in clinical practice.
And that's all right, and you know, I think this is widely used. I'm presenting here to a study of my group because we've been paying attention to this issue, and then as you can remember, HIV decreases CD4 and increase the CD8. So the ratio is decreased in patients untreated for HIV. Then, when you give antiretroviral therapy, this is reversed, the CD4 increase and the CD8 T cells decrease. But in those, you know, in whom the ratio remains low, so with incomplete immune restoration, then this can be used as a marker of the risk of developing comorbidities. And these two studies show this. The first that I want to comment is the one on your right. And here we show in the cohort of patients from our hospital that patients that did not develop any event, any non-AIDS event, have a greater CD4, CD8 ratio, significantly higher CD4, CD8 ratio than those patients developing any type of event, being malignancies or being ischemic heart disease or non-AIDS related death. There were differences in all of them. And we were able to identify a cutoff point of 0.4 differentiated those with and without elevated risk of developing non-AIDS events. And this has been demonstrated by other groups as well. And in your left, what we show is that the important finding is that maybe this is mainly driven by the CD8 count. And here we show just, you know, a couple of our findings, and it was done in collaboration with a cohort in US. And here you can see that those with a lower CD8 count had more immune activation in your left, shown by the double marker of CD8 and the negative CD828, and also a lower number of naive cells. So a high CD8 count and a lower CD4-CD8 ratio are clearly markers, predictors of the risk of developing non-AIDS event.
So certainly one of the ways of managing that is to maintain continuous antiretroviral therapy. And that was something that we learned from SMART, that the individuals who interrupted treatment were getting a reactivation of their immune system and were more likely to develop a range of different events, most notably cardiovascular events. And then in the START study, looking at the timing of the introduction of antiretroviral therapy, we saw that same range of inflammatory markers being relevant to events, and that the group that deferred initiation of antiretroviral therapy rather than initiated immediately, remembering that this wasn't in Freiberg stage, these were people with established chronic HIV infection, there were fewer events in those who started antiretroviral treatment promptly compared with those who deferred initiation, and that difference in events was correlated with a range of different inflammatory markers of the type that Santi has mentioned. So let's move on to what we can do other than prompt initiation of antiretroviral therapy to reduce chronic inflammation. So in recent times, we've had a specific use of a statin drug. The Reprieve trial used pitavastatin, but it's assumed that similar effects will be observed as they have been in clinical trials in the general population with atorvastatin or rosuvastatin, our other preferred statins. And we know that statins, not only as HMG co-reductase inhibitors, reduce LDL cholesterol, they also have an anti-inflammatory effect, as demonstrated, for example, in Paul Ridker's Jupiter trial in the general population, which targeted individuals with normal lipids but elevated CRP. So in Reprieve, what we saw is that individuals with low to moderate cardiovascular risk and in general fully suppressed HIV RNA who were randomized to pitavastatin or placebo saw more MACE events, which is major adverse cardiovascular events, or MACE and death events, than those who were on the pitavastatin. So the anti-inflammatory effect and the lipid-lowering effect of statins is potentially one way of addressing this particular comorbidity associated with inflammatory drive. Peter Hunt has also done a small trial with valganciclovir to look at the role of CMV activation as a potential contributor to inflammatory markers. The study was successful in terms of the valganciclovir reduced CD8 activation. The problem was, of course, that valganciclovir has some adverse effects, meaning that it's not really a practical thing to use in the long term, and that CMV tends to reactivate after the removal of the product. Similar studies that were done with valacyclovir, looking at whether there was a particular role of herpes simplex virus, were less successful. And then we've also had some studies that have looked at the use of prebiotics or bovine colostrum to try and address the microbial translocation issue. And these have some value in short-term changes, but overall the studies have been negative when looked at over periods beyond, say, 3 months of intervention. And then there's also been some studies that have compared regimens that contain 2 antiretroviral drugs, such as dolutegravir with lamivudine, versus 3 antiretroviral drugs, 2 nucleosides plus a third agent, showing that the changes in inflammatory markers are very similar with 2 drug regimens to 3 drug regimens. And so it's really the suppression of immune activation is driven by the suppression of HIV RNA rather than by a particular choice of regimen. Santi, what about other things that we might be able to use that target inflammation?
Yeah, this is a study that I like a lot. It is a study that maybe you remember was done in HIV-negative individuals. And what they showed was they gave patients canakinumab, which is a monoclonal antibody that inhibits IL-1, and then it decreases IL-6. And the interesting finding was that patients receiving canakinumab had a lower incidence of myocardial infarction and another ischemic heart disease events. Here, what we are showing here is a decrease in the activity in the inflammation. You can see in these photographs that there was a compared to baseline, a significant decrease in the atherosclerotic inflammation in the aorta. And I think that this is very, very significant. And also, what I think we should explore is the possibility of inhibiting the viral particles that we mentioned as drivers of inflammation. And we have now drugs like fostensavir. The fostensavir, you remember well, blocks the binding of GP120 to the CD4. And doing that, it could, in addition to antiviral activity that it has, it could also inhibit the cascade of inflammation by binding of the B20 to the receptor in the CD4.
Thank you very much, Santi. So that's a very interesting program. And I think just in terms of summarizing things, we've discussed how immune activation persists in people with HIV infection despite prompt initiation of antiretroviral therapy and complete suppression of plasma HIV RNA, that we have some specific antiretrovirals that have immune system effects, but we perhaps need to also think beyond antiretrovirals about other things that may contribute to suppressing that chronic immune inflammation and inflammaging effects. And I think we've seen that in the REPRIEVE trial, the story that additional agents to help manage down comorbidities is an important part of intervention to try and deal with this accentuation of comorbidity and the inflammaging phenomenon that we see in the setting of HIV. So Santi, I'd like to thank you for a great discussion and thank you for participating in this activity. If you continue in the program, you will have some questions and an evaluation to perform, which helps us develop better programs for you. Thank you very much.
This program was presented by Medscape Education Global.